At the outset, I'd like to thank Dr. Vijay Kumar Bada sir and Yashoda for inviting us here. So, my topic today is post gastrectomy complications, the surgical aspect. Now, you've heard what the complications are, how do you medically manage them. What I am looking at is when do we actually intervene, when do we reopen the patient, and this is always a dilemma. So, grossly they can be divided into early, which is within 30 days, hemorrhage, anastomotic leak, stump blowout, stump leak, any acute obstruction in the immediate post-operative period, or we can talk about late complications, which could be either due to a obstruction developing later due to an adhesion or a stricture, or it could be ulceration, stomal ulcerations near the gastrojejunostomy site, or blind loop syndrome, rheustasis, gastroparesis. So, why do all these complications occur? So, you have to understand the physiology of how these complications occur also. When you are doing gastrectomy, you are removing a reservoir, you are interrupting the pyloric sphincter mechanism. At the same time, you are transecting the vagal nerve and you disturb the continuity. So, all these could be cause for all these complications. You have already heard about diurnal stump leak or stump blowout as it is called. So, what happens in most of surgical interventions post surgery is, it is very important to know when to intervene. A lot of patients are lost because the surgeon feels that no, it can't be a complication, or he's scared of reopening the patient, and sometimes that pushes the patient to a point where you cannot bring him back. Once a MOD sets in, you can't bring him back. So, in diurnal stump leaks, if you already have a drain in place, you have nutritional access, then you can manage him conservatively, give antibiotics. If he develops peritonitis, then you have to do a laparotomy. You should not hesitate at any point. The main principle is, one, sepsis control, second, drainage of any fluid, make sure nutrition is there, wound care is there, and if it is very badly inflamed, sometimes you will have to do a duodenostomy. I think Hazrat already touched upon these factors. What are the risk factors? Extensive inflammation around that site, devascularization of the stump, any hematoma post-operative, pancreatitis which is not in your hands. You have some mitigation strategies, but these are not foolproof. Again, this is a summary of what is to be done. Duodenostomy is something I think we should all learn. As time goes, we are forgetting how to do a tube duodenostomy. Nutritional access is very, very important. So, if you have a feeding jejunostomy, sometimes you don't even have to go in. If you don't, you might have to endoscopically put an NJ to maintain nutrition, or you might have to do a lavage and do a feeding jejunostomy. This is from up to date, we have already covered most of it. Let us go to the next topic, afferent loop syndrome. So, when you do a loop jejunostomy, gastrojejunostomy, there is always an afferent limb and an efferent limb. So, whenever the afferent limb gets blocked due to any reason, you might have afferent loop syndrome, and the characteristic feature is there is sudden bout of vomiting and the patient has relief. It can be due to any reason. It could be a kink, it could be a volvulus because you did not close an internal hernia, mesocolic rent. It could be due to an adhesion, temporary adhesion, or it could be to some narrowing at the anastomotic site. Now, if it settles, if it is just a minor narrowing and it settles with conservative management, it is okay. But if it does not, then there is no point in postponing it. It is very important to diagnose the cause and treat the cause. So, most of the internal herniations can be corrected, or you can convert it into a Roux-en-Y anastomosis. For diagnosis, you can use an upper GI contrast study, endoscopy, CT, or any imaging like CT with oral contrast. What can you do? You can convert a Billroth 2 into a Billroth 1, very rarely done. Commonly what we do is convert it to a Roux-en-Y. Okay? You just staple it, bring it down, create an anastomosis. So, a part of surgery for most of these long standing complications is like strokes, because whatever the symptom is, ultimately the surgical options will be one or two. You can do them, Roux-en-Y or external diversion. So, again efferent loop is more important, because now the patient, whatever food that you eat will not go down. Again, most of the causes are mechanical. It could be due to poor reconstruction, any bowel adhesion or kinking. Long term, sometimes within 1 or 2 months, they can come back with a recurrence. So, again in all these conditions, it is very important to evaluate why it happened and treat that cause first, treat the source.